I'm very excited to be here. I want to thank Malka Nielsen and the Keystone Dental Group, and I'm going to give a shout out to Carol Sachs and Michelle Vedder. Superb ladies, thank you very much for everything you do. All right, so I've been doing graftless procedures now for the better part of, I'd say 12, 15 years. And we've seen a lot, we've done a lot, and we've learned a lot. So today I want to share with you some of our experiences, and the title is a little bit thought-provoking, re-evaluation of the all-on-4 concept. Now, when we start looking at full arch implant rehabilitation, it has undergone massive change. I don't know any aspect of implant dentistry that has so many facets, so many changes over the last 10 years. Grafting, graftless, zygomatics, pterygoids, do we reduce bone, do we not reduce bone? The all-on-4 process or concept has revolutionized, whether we want to admit it or not, a lot of patients' lives, and it's revolutionized your practices, right? And everybody seems to want to do this. So the thought process today will be, is this the way to go all the time? So let's start defining what all-on-4 actually is. And Human did a great job giving us the fundamentals, but I'm going to quickly go through what it means. Essentially 4 implants, 2 straight, 2 tilted, full arch provisional, immediately loaded. And it's all about the graftless procedure. It's all about trying to give patients teeth the same day. Now, we've done a lot of graftless, but I'm going to be the first one to say it's kind of become a cult. And when I say that is, it's changed so much that everybody seems to think we have to do this graftless for everybody. There is nothing wrong with grafting when you need to graft, right? So we shouldn't be approaching patients that, okay, we have to do this graftless, we have to give them 4 implants, we have to give them teeth the same day. Human already talked about bone availability. The all-on-4 classic protocol was designed for patients who only have bone in zones 1 and 2. There's a pneumatized sinus, you can't go further back. That is the reason to tilt the posterior implant, right? So it's a specific treatment concept. It's a specific surgical, prosthetic, and not forgetting, maintenance protocol. And I'm going to tell you, it has abundant scientific documentation. We know that. There's data going back 15 years plus, multi-center, which shows that this concept truly works. So I'm not here to say that it doesn't work. I'm here to say, look at your patients a little bit more closely. So why has it become mainstream? Less costly? I'm not sure about that. I think the corporates like ClearChoice have set the fee for all of us, right? No grafting, patients love that, when you don't have to talk to them about grafting. Teeth the same day, when you can have that conversation whereby your teeth are coming out, we're placing implants, we're providing you teeth the same day. Easier, questionable, and digital technology can solve all your problems. Or can it? Right? Digital technology is amazing, and we utilize a lot of digital technology, but it's a tool in your armamentarium. So what problems have we seen? What happens if a strategic implant fails? For the surgeon, no big deal, right? 10 minutes, take the implant out, another osteotomy, let's put another implant in. What happens to the restorative dentist? Is the laboratory technician going to give you a break on fabricating another prosthesis? Probably not, right? So it has more of an impact for the restorative dentists. Are there cases which you wish you had over-engineered, where implants failed? Patient had some health issues, the patient was a bruxer. Do we need massive bone reduction? And why is it every brochure we see, every publication that comes out, there's a ton of bone reduction and there's pink prosthetic everywhere? Do we really need to do that? And I'm going to question that. Is it a standard protocol for all patients? It's become a panacea, right? Even in my practice, when I'm treatment planning a patient, my treatment coordinator will say, oh, is this going to be an all-on-4? I said, no, it's not going to be an all-on-4. It's going to be an implant-supported restoration. Because every edentulous patient somehow seems to have all-on-4 done, right? And digital technology, as great as it is, and you're going to see like many examples of digital technology, be careful. you have to know how to do this the analog way before you jump into the digital world. When I was a resident at SC, this quote was presented to us many times. It's by Marla Devan: "Our goal should be the perpetual preservation of what remains rather than the meticulous restoration of what is missing." Think about that. Our goal should be the perpetual preservation of what remains rather than the meticulous restoration of what is missing. So what I'm going to share with you in the short time we have today is my mistakes. I've been humbled over the last many years, and I've done things wrong, and I've seen them come back to me. Things that I've learned and things I do differently today. These are the questions I'm going to ask, and we're going to go through them one by one. Let's start with this one. Do we need aggressive bone reduction? And I know some surgeons will look at this and say, this is great. If you can't reduce this amount of bone, you shouldn't be doing this procedure. Right? That bone is holy grail. Once you reduce it, it's gone. It's gone. You can't put it back. What happens in that one patient? Say the implants all fail. How are you going to retreat that patient? This is a Facebook all-on-4. I don't know what happened here. I don't know the treatment planning behind it. Maybe the patient had super amount of vertical maxillary excess and tons of bone, but I'm hard-pressed to believe that this amount of bone can be removed. This is one that I was involved in, which you just saw. Right? I treated this particular patient with Human, and this is the patient. Right? And when you're looking at it, you're probably thinking, how do we treat this patient? What do we do? And I'm going to give you a little backstory to this patient also. Do we remove bone for this patient? Has the patient lost vertical? The patient has a severe amount of wear. And we assume we have to open the bite, right? But in management of wear cases, sometimes there's compensatory over-eruption, and the patient hasn't lost vertical. So we need to create space from somewhere. Now, this particular patient was from a Mexican drug cartel. No lie. He came into the office. I used to be on the 16th floor of the Morgan Stanley Tower in Oxnard. And he came in and said, I want you to do what you did for my friend. If you screw it up, I'm going to throw you out the window. I said, nice guy. So what do you do with patients like that? Two things, right? You either set your fee so high that they're not going to do it, or you say you're not good enough. So I had done something for his friend, so I was kind of committed. So I quoted him a ridiculous fee. Give me 15 minutes. I want to come back, got some money to collect. And he told me he'd been in prison 3 times for manslaughter and this, that, and the other. He came back with a bag of hundreds. My staff are like shaking. And the next thing you do, what do you do? I pick up the phone. Hey, Human, I got a really nice patient for you. I have a really nice patient for you. In any case, let's see how we treated him. So this was him. And yes, we can save 1 or 2 teeth here. He was not interested in that. And to try and restore those teeth would have taken a lot of work, right? And the root length, for me, wasn't justifiable. So Human went in. This is not an error by Human. It's an error by me. The reason I'm saying it's my error is because I had prescribed an acrylic titanium restoration, which today I only use opposing a denture because it requires way too much bone reduction. Right? So bone reduction done, implants placed, and this is our patient. And we immediately loaded him over 2 days, Monday and Tuesday. So Wednesday morning, I'm usually at USC. I do literature review with the residents, and my phone keeps going. And I tell my staff not to disturb me when I'm at the university. Keeps on going, keeps on going. So I said, okay, I'm going to excuse myself from the room. I excused myself from the room. I said, hey, Laura, what's the matter? Can you tell me what's going on? Armando's here, and he's broken his teeth. Well, I'm thinking, oh, my God, what am I going to do? So I said, okay, I'm going to finish up, and I'll be there in about an hour. So I'm driving down the 101, and I call my wife. I go over my life insurance policy. The one thing I regret is I told her I'd hidden some extra money, which was a big mistake. And I walked into the Morgan Stanley Tower, and usually there's a 6-foot-tall, 6-foot-wide guy, security guard, standing there. And I walked into the doors, and there was like a 5-foot-nothing Filipino security guard, and I'm thinking to myself, God does not like me. Because I was planning to take the security guard upstairs. I walk into the office, and my staff are like white as a sheet. And most of my staff are Hispanic, so it was kind of funny to see that. I walk into my office, and then I walk to see Armando. Armando, what happened? And I'm standing away from the window for obvious reasons. Armando, what happened? Armando, for God's sake, can you tell me what happened so I can help you? He says, Doc, I'm too embarrassed. And at that point, I was like, okay, it wasn't my fault. Because I was drinking some beer, and I was opening the bottles with my teeth, and my teeth broke. So when you immediate load, make sure your patients don't open bottles of beer with their teeth. In any case, this was done a long time ago. This is one of the first copy mill frameworks, and we've over-engineered it. And this is how the patient finished up. And I'm looking at it thinking, it looks not bad. What were the errors? All right? I'm going to tell you. Look at the amount of bone the patient has. This is not an indication for all-on-4. I don't care what anybody says about complexity and cost and what have you. I don't think it takes more time to place 2 additional implants and over-engineer this case based on what we saw with that patient, how the patient presented. Right? Easily place 6 implants. We have bone in zones 1, 2, and 3. No reason to even tilt implants here. Right? Do we need to do this bone reduction? I cringe when I see that amount of bone reduction, because today, this would not be acrylic resin titanium. It would be zirconia. And I maybe should have even treatment planned PFM in those days. Right? This is way too much bone reduction. That is my mistake. This is 12 years on. He came out of prison, phone rang, it's Armando. I need to see the doctor. And I'm thinking, oh my God. He's come out of prison, and he came in like this. Why did it break? Too much titanium, not enough acrylic. Right? We'd over-engineered the framework. But saying all of these errors that we made over time, still in his mouth 12 years later. Right? And he's in his mid-70s now, and hopefully over the next 10 years, somebody's going to get him, and I won't have to worry about him anymore. So what do you do in patients like this, who come in intact alveolus? Are we going to reduce bone in this patient? Right? Terminal dentition. Once again, when you start looking at this particular patient, can we save a couple of teeth here and there? I'm sure we can, but there's too many things to think about. But as clinicians, we have to give them options. All right? We come to a diagnosis, lack of posterior support, caries, periodontal disease, and the patient wants the bimaxillary protrusion addressed also. Right? So we can talk to the patient about sinus lifts and implants for orthodontic anchorage and all that kind of stuff. There's nothing wrong with that. Right? And our decision-making is based on patient desires, what they want to a degree, cost to a degree, and health history. And after that discussion, we decide where we're going. So for this particular patient, we did make the decision to remove teeth and place implants. So is additional bone removal for this patient justified? Are we going to just, for lack of a better word, hack the bone down to find a platform where we can place the implants and to provide that pink prosthetics for this particular patient? And I would question that, right? And it really depends on a number of things. Smile and lip length, which Human had talked about, and over-eruption of teeth. You've got to look at all of these 3 things. So when you look at this patient's mandibular teeth, they have over-erupted. And if I'm trying to reposition the incisal edge for anterior guidance, I may need to do some bone reduction. Right? Over-erupted teeth, they over-erupt, and you get a triangular edge of bone, which is useless for implant placement. Right? So this is our patient. We're going to reposition the incisal edge, both in the maxilla and the mandible, and day of surgery. This is day of surgery. We have our provisionals pre-milled, And this is what the patient looks like post-op a few days later. Now, when we make such dramatic changes for patients, we always put them through a second round of provisionals. Not just to work out aesthetics, but phonetics, cheek biting, occlusion, all of that kind of stuff, so that when we get to the final, there's no mistake. So you're probably asking yourself, so why did you do bone reduction in the mandible? And the only reason for that, because the width of the bone didn't allow us to place regular platform implants. We needed to reduce it for incisal edge position and to get an adequate volume of bone to place implants. But this is our patient with the definitive restoration. Graftless, didn't have to reduce bone, not classic all-on-4 protocol, and I would argue that I think we did the patient a service by not reducing bone. All right, and this is our patient at 5 years, functioning quite well with the zirconia-based restoration in both the maxilla and the mandible. Why didn't I do acrylic resin titanium in the mandible? Because of the space that would have been required. I'm very comfortable with zirconia to zirconia restorations today. Now, do we need to reduce bone sometimes? Of course we do, and there are many factors that go into this, and Human eloquently described those. So let me show you Etelvina. She came in, and for a Mother's Day present, her kids provided her with upper teeth. They wanted her to fix her upper teeth. Lower teeth, financially, she couldn't afford right now. So that's for a future project, and her teeth are failing. Right? Her teeth are failing. And once again, you look at some radiographs, and are there 1 or 2 teeth we can save here? Yes, there are. And potentially those molars, if they don't get in the way, we leave them alone. Right? There's no reason to take out those posterior molars because they can provide us with some reference points. So this is Etelvina. And once again, we remove teeth, provisionalize, immediate load. And a lot of the questions around this type of prosthesis at immediate load, does it ever fracture? Sometimes. We reinforce it with something called Fiber Force CST, which is a silane-coated fiber, works very, very well, and it reinforces the acrylic restoration. And this is our patient, provisional. Now, you guys have heard a lot about Nexus, and this was one of our first cases. And I'm very critical. I never thought that this would fit. I never thought that it would work. We scanned the patient, sent the file to Australia. We got things back. And honest to God, I was not expecting it to fit. Right? So what we did, we'd done a digital workflow for her, and I'd also done an analog workflow. So we made 2 restorations for this lady. Right? So I could compare, 1, if my impression making was correct and my models were poured correctly, and 2, I would compare the fit of both of them. Now, the strength of the restoration in limited amount of space, the zirconia superstructure is supported by a titanium substructure. And the titanium substructure, everything is digitally milled, and it provides us strength in limited space. You know, durability and definitely the digital capability is a huge advantage. So this is the restoration, and took it to the mouth, put it in, and I was, for lack of a better word, shocked that it fit. You know, I was always telling the Austrian team and the Keystone Dunk, I said, this can't fit, this can't fit. You can't scan around an arch, right? But I was pleasantly surprised. So this is our patient. This is our analog workflow and our digital workflow. Now, why does the digital workflow hold merit? Fewer appointments, it's digital, cost-effective, and it saves you time. And whenever I incorporate digital technology, I'm looking for that. I'm looking to see how quick it is, how much time can it save me, and can it produce me a better or an equivalent result? If it can, I look at digital technology. Right, so this is Etelvina with the restoration in place. So the message there was don't reduce bone unless you have to. Don't look at those brochures where they tell you just take away 3, 4, 5 millimeters of bone just for the sake of implant placement. So next question, are 4 implants enough in all situations? And do we need to tilt implants in all situations? Let's have a look at Jonathan. Jonathan has a periodontally failing dentition. He's very embarrassed. He comes in and tells me I've not been for a date for God knows so many years. He lives with his cat, and he's just embarrassed. He's embarrassed to speak to people. He doesn't even want to open his eyes to take a photo. Periodontally failing dentition. Can we save 1 or 2 teeth? Possibly, but in the overall scheme of things, these teeth are going to be coming out. Right, so what are the challenges in Jonathan? Periodontal disease, terminal dentition, over-erupted teeth, and large masseter muscles. So we have a couple of risk factors here, right? Perio and force. And I'm thinking to myself, are 4 implants going to be enough here? He's a young guy. He's 59, right? He's going to live maybe another 25, 30 years. Are 4 implants going to be enough here? Right, so the first thing we do is, despite his teeth coming out, we send them to the hygienist just to get them used to the fact that they're going to be having maintenance. And if they show up for the scaling, we put them through scaling 2-3 visits to see what their compliance is going to be. Because we all know that these types of patients don't have the best oral hygiene practices in the world, and you do this type of extravagant restoration, and suddenly things start to fail. And we all know that the bacteria that cause this problem will live in his mouth for at least a year afterwards, and we need to keep this patient on very close recall. So the treatment plan was to clean him up, remove teeth, place implants, do a prototype, and do zirconia-based restorations. So how many implants do we place in Jonathan? Do we place 4? Some people say 4 is enough. Do we place 6, 8? And the advantage of placing more implants is you're able to segment the restoration. Right? Remember, graft less and all on 4 is not a panacea for treating these types of patients. We have to exercise common sense, and we have to exercise our thought process and say, how long is this patient likely to live? Right? And what are we demanding from the restoration? Right, so do we need to tilt implants? How much restorative space do we need? He's been treatment planned for zirconia-based restorations, so we're not going to be reducing bone that much. And what are our risk factors? So we did reduce bone in the mandible, and the reason for that is he had over-erupted teeth. Once again, I had to reposition the mandibular incisal edge, and we had this triangle of bone, and we take that triangle down to give us enough buccolingual dimension to be able to place the implant. So we get everything ready from a laboratory perspective, and this is our patient on the day of surgery. Right, we take teeth out, immediate load, and what did we do? We placed 6 implants in the maxilla and 6 implants in the mandible. All the implants were placed straight. This is our prototype, 1 week post-op. Prototype to test the aesthetics, phonetics, occlusion, make sure that everything is in the right place. And then we finish it up with zirconia-based restorations that are minimally layered. And this is Jonathan, how we finish him up. Right, so we can predictably take a patient from a periodontally failing dentition, address all the risk factors, and be confident that we can provide the patient with a fixed restoration which is going to last. Look at the change. Look at the change in his appearance. Look at the change in his hair. Look at, this is something you all know, we change patients' lives with stuff like this. But it's not all on 4. Another question, can every patient be immediate loaded dogmatically? Teeth in a day, smile in a day. They all want that for sure, right? They all want their teeth in a day, and we try to think of processes whereby we can do that for patients, right? But let's look at it. What is immediate loading? Immediate loading, when you define it in a full art situation, is providing patients teeth the same day, and we're putting them in function, right? And we're hoping that we have mechanical stability from the bone, biological stability from the bone, and usually type 2, maybe type 3 bone is the best type of bone to place implants in. And we gauge the stability by our torque on our implant devices, sometimes resonance frequency analysis. Now, what are the risk factors in immediate loading? Surgical technique, poor bone quality, that's when a longer implant has more merit, right? And operator skill. This is not easy. It is not easy. It takes years of practice to be able to load patients immediately day of surgery. Right? Now, what are our relative contraindications? Uncontrolled metabolic disease. Patients has diabetes, hyperparathyroidism, drug abuse. Patients who have undergone ionizing radiation. Right? Severe parafunction. Right? Non-compliant patients, patients who don't want to look after their teeth. This is Katrine. Katrine is from Germany. She has a failing maxillary dentition. Okay? This is how she looks. She'd had implants failed posterior right, she's had implants failed in premolar region, and she's going to lose her anterior teeth. Our challenges are that she's diabetic, she has a history of implant failure, doesn't want prosthetic gingiva, and does not want to be in a removable partial denture at any point during the whole treatment process. So what do we do in situations like this? Right? We have to go back to conventional dentistry. We can still prep teeth. We can still do tooth supported provisionals. There are still some options to give patients teeth the same day without taking all of their teeth out. So we over-engineered her. We did extract. We did do sinus lifts. We did provide patients with the tooth supported provisionals. We did over-engineer the case because she had a history of implant failure. She does have diabetes. Right? And then we went to the definitive restoration. So once again, we chose some strategic teeth that we could keep temporarily while all the surgery was being done. And this was on the day of surgery. She had the tooth-supported provisionals while everything else was healing. And she woke up, and she looked at her teeth, and she says, "You know I'm from Germany, right?" I said, "I know that." She goes, "I don't want American teeth. I don't want bright white, everything straight." I said, "Okay." So we stained it with some of the Kerr stains, and then she said, "I don't want British teeth either." All right? So this is 3 days post-op, and things are healing. All right? So the implants are healing, undisturbed. The grafts are healing, undisturbed. And the day comes, implants are integrated. We've made an implant-supported provisional. We put this in her mouth, get her feedback, get her husband's feedback. We're going to change a few things, get to the prototype, and ultimately we provide Katrine with a zirconia-based restoration. Tooth-only, number of implants, split into 3 sections. If any of these sections fails, I can deal with that section separately. I don't have to do cross-arch stabilization here. We've got plenty of implants to be able to deal with complications for the future. And she's only 51. Right? She's going to live a long time. And this is Katrine. When do we graft and when do we use zygoma? Right? When I look at Facebook groups on zygomatic implants, I'm going to tell you they are being overused. Overused. I don't think just because you didn't get distal stability from an implant, you have to go straight to a zygoma. It depends on a number of factors. Right? We can still give patients teeth the same day. It can still be done. I think zygomatic implants are an amazing treatment modality for patients. In treating patients like this case was done by Human, you showed it earlier, and there's really nowhere else to go for this particular patient. Right? Very challenging, but doable because we have zygomatic implants. What do you do in a 32-year-old? Failing dentition, pneumatized sinuses, compromised molars, drug abuse, bruxing his teeth, irregular occlusal plane. He's in his 30s. He doesn't want to wear a removable appliance, which is quite odd, right? Because he comes in without teeth, but he still doesn't want to wear a removable appliance. The demands these patients place on us. And there's no bone in posterior maxilla. So same thing. We extract teeth. We place implants. We're going to over-engineer these patients because of risk factors. He's in his 30s. Are 4 implants enough in a 30-year-old? Some people may say yes. I don't think so. Because this patient has to live a long time. And as Peter had mentioned, we've been in the game long enough to know that implants fail. right? So we try to treatment plan this patient systematically. We get everything ready from a laboratory perspective. This is immediate load. We place the implants in the anterior maxilla, and he's grafted. So he walks out the day with fixed permanent teeth, and he's grafted at the back. There's nothing wrong with that. There's absolutely nothing wrong with that. Will it add a little bit of cost? Of course it will. But in the overall scheme of things, in the lifetime of the patient, that cost is going to be negligible. And we finish the patient up with 6 implants and a zirconia-based restoration. Right? There's been some ortho, there's been a number of things happen to this patient to correct occlusal plane, but we've over-engineered the patient. And this is how the patient looks. Over-engineered, 6 implants, patient had teeth all the way through, wasn't your traditional all-on-4 concept. Are implants better than teeth? It's a question we have to ask ourselves. Are implants better than teeth? This is Tammy. Tammy came to see me a few years back, wants a beautiful smile. This is how she looks. Right? We take a few radiographs, and not looking too bad, right? Not looking too bad at all. A little bit of caries, endo maybe failing, maybe a couple of implants, maybe veneers, what have you. We come to our diagnosis, caries, perio, failing restorations, and then we start treatment planning. So what should the treatment plan be for Tammy? And the question you're probably asking, because I'm talking about a reevaluation of the all-on-4, is are you going to remove all her teeth and place implants? Of course I'm not. I'm not going to do that. Treatment plan for Tammy was caries control, perio, endo, maybe some crowns, some veneers, and maintenance. Tammy disappeared to Texas. And she was told, why are you spending so much money on crowns, veneers, and all this kind of stuff when it's going to fail anyway? Why don't we just do implants from the get-go? Shocking. Shocking, but it happens a lot. It happens a lot. And this is Tammy. She comes into the office crying. This is a provisional restoration. And this is how she looks. If Tammy had had nothing done, she was in a way better position. Right? Provisional's fracturing, not a good situation. So the message here is all-on-4 is a great treatment modality when indicated, but keeping good teeth is way better. Way better. Teeth are way better than implants. Right? So considerations for Tammy. Implants are in a poor position. Poor aesthetics. We have lost tooth, tissue, and bone. And we're going to probably have to do pink prosthetics here. Right? So we get Tammy ready for immediate load. And I send her over to Human. And Human does the surgery. And he has to place the implants in a specific way. He has to take those implants out and somehow manage to work backwards from our surgical guides so that we can develop appropriate emergence profiles. So the implants go in, and this is how Tammy surgically finishes. Right? Tissue is flat, but it's healthy. And this is Tammy. This is our prototype. We're testing aesthetics, phonetics, occlusion, all of those things that we do before we finalize. And we realize from a tooth proportion perspective, we're going to need to add some pink ceramics over here. And this is Tammy finished up. Right? And she looks good. She looks good. When I see this series of photos, it makes me very sad that somebody can convince Tammy to extract perfectly good teeth and say to her that implants are going to solve all your problems. And patients often come in to see us, and they ask us, how long is it going to last? Right? Is there a lifetime warranty? What in your life is guaranteed? Maybe your mother-in-law moaning at you, that for sure is guaranteed. But what else? There's not many things that last a lifetime, right? And patients have to know that if their teeth are terminal and we are extracting to place implants, they're going to have to revisit this at some point. It's not going to last forever. If they went out and they bought a Bugatti for $3 million. Is that going to last forever? Because patients come to us, they pay a high fee for these types of restorations. They're thinking, this is going to last forever. We've got to get that straight from the get-go. Right, so this is Tammy, and once again, makes me quite sad when I see these series of photographs. Right, so it's really all about diagnosis and treatment planning. So let me share a case with you, Kelly. Kelly came to see us, once again, suffering from periodontal disease, numerous problems going on, and she's going to lose her maxillary teeth, most of them. Right? She has periodontal disease, but we have key teeth that are savable. Canines and first molars are savable. Right? So these 4 teeth, and they're the cornerstones, right? Recreating that canine eminence is going to be hard. So we look at this really, really closely, and we say, you know what? We're going to save the canines and the molars. We're going to have you under strict, perio recall, but we're going to save these teeth. Right? She doesn't want prosthetic gingiva, and she doesn't want to be without teeth. So, treatment plan, once again, we take the patient through initial phase perio. We're going to keep teeth. We're going to create a roundhouse provisional, and we're going to eventually provide Kelly with teeth and implant-supported restorations. Right? So we get everything ready in the lab. We have our provisional ready, which is milled. And on the day of surgery, teeth are extracted, implants are placed, 4 teeth are prepped, and we provide Kelly with a fixed tooth-supported provisional. That's, I would say, the most aggressive thing we did. We prepped teeth, which maybe shouldn't have been prepped, but to satisfy her requirements of fixed teeth all the way through, and that is something that we had to do. This is Kelly, 2 days post-op, and you look at the soft tissue, it doesn't look so great. We're going to alter the ovate pontics and what have you. We altered the ovate pontics, and now we have a situation where we have 4 teeth that are healthy, implant-supported restorations, 6 implants placed. This is Kelly prior to finish, and these are Kelly's definitive restorations. Single unit restorations on molars and canines, and splinted restorations on implants in 3 sections, premolars and 1 from lateral to lateral. All right, and this is how Kelly finished up. All right, so when we're thinking about the all-on-4 concept, the concept and the treatment protocol are designed for a specific purpose. We tilt implants for a specific purpose when we can't place implants straight. We don't have to tilt all the time. Right? We can provide patients with tooth-supported solutions to transition patients. There are many ways to do this. What did we used to do before implants came along? It seems to me that this all-on-4 concept has come, and we've forgotten how to prep teeth and do the classic perio-pros type transition for patients. And we can't forget about that. It's all about diagnosis and treatment planning. There's no company that is going to give you a solution in a box that is going to solve all of your problems, whether it be digital, implant parts, abutments, what have you. It's all about diagnosis and treatment planning. And as dentists, we look for an evidence base, right? But the reality is, in dentistry, our evidence base is not so strong. We don't have randomized controlled clinical trials for everything we do. Look at this digital technology, how quickly it's changing. What you're seeing today is going to be very different in 6 months. So when we don't have an evidence base, we've got to exercise common sense. Once again, you've got to ask yourself, the patient in the chair, if it's a family member, not your mother-in-law, what would you do? What would you do for this patient? Right? And if we don't know what to do, there are many people in this room here today that have done it way longer than I have. I would go to them and say, hey, what was your experience? How did it go? What problems did you have? Right? And this is what we do at meetings. Right? So there's one last quote before I finish by L.D. Pankey. If patients knew what you knew, they would want what you want. If patients knew what you knew, they would want what you want. And with that said, I'd like to thank you for your time and attention.
Thank you, Saj, for a wonderful presentation. I guess I should have waited after your presentation for my questions. You basically all answered. What I don't understand is, and you know, your last case is, why would somebody even think about an all-on-4? So do you see the field now shifting towards standardized treatment for a single tooth suddenly becomes an all-on-4?
You know what, unfortunately, I will say that I have seen that. Patients have come in and they've said, I've been to a few places and they've told me I need all-on-4. And
is that mostly in Texas or also in California?
It's everywhere.
It's everywhere?
It's everywhere. It happens, and you know that as well as I do.
Yeah. Where do you think the trend is coming from? Is it the lack of training in school? Is it a lack of critical thinking capability of the doctors? Is it companies pushing? What is it?
You know, I don't think it's training in school, because in school they only get so much time to train certain procedures. So
yeah, in school they don't get trained.
Right? So, well, I wouldn't quite say that. You know, I'm not sure where it's coming from, but I feel there's a misconception that it's so easy that you can do it. And to do a full mouth rehabilitation on teeth and implants takes longer and what have you. And they're finding this to be an alternative solution. And maybe it's been driven by the corporates, the corporate implant centers.
Now, I try to, you know, every time we have a complex case to the patient, we try to give them multiple treatment options. And the ultimate question is always, Doc, what would you do if this were you or your wife or your mother-in-law? Because then we would do the opposite. Do you think that patients ultimately listen to your advice?
They do. But today, I think patients have become more savvy with all the information available. They are going for 2, 3, 4 consults before making a decision when they're spending that kind of money.
Yeah. And I think they should. But clearly, I think the theme of today, I think becomes more and more evident, is going to be treatment planning, diagnosis is the key to success. It's not using this technology or this implant or this screw.
Sure.
Or this scanner. It is really back to fundamentals. And I think it's going to become very obvious. And a wonderful presentation.
Thank you.
Thank you so much.